So either she's in some type of spasm with those tissues, or the joint capsule is already torn, or just stretched out, or neurologically just not engaged. But I would reduce her and literally just slip right out. And that was she was a first time dislocator. I remember her very well.
Wow.
Yeah, that's the only one I've ever seen like that.
Gotcha.
Yeah.
Any difference?
Well, there's some people that have a condition.
Oh,
What do you call there's some people that have loose joint condition, some kind of disease. I don't know.
Yeah, people are really Ehlers-Danlos.
Yes.
Yeah.
So, but
I didn't ask. I didn't know anything about Ehlers-Danlos back then. I guess that's possible. This was years ago. So yeah, she could be hypermobile. Could have been.
Yeah. First time dislocators and chronic dislocators. Do you guys have any feedback on that?
second, third time. I mean, it's surgical. I mean, I hate to say it, but yeah. I mean, some people. Let's say, Otani, he's sublux, which he's the pitcher and he can throw pretty fastball, which means he's got MDI. So I assume he'll be fine. But some people, the same. Go ahead.
Hi, my name is Sky, and I'm from the University of South Florida, and I'm going to be relocating 4 joints.
All right.
Girl. Not a girl.
Last one. There you go. Subluxation might be the end of the career. So
Okay, he'll be great. You know why? Well, you know why she'll be great?
why?
Because he's a right-handed pitcher. He's a left-handed batter and a right-handed pitcher.
Right.
We don't.
That's right. That's right. Yeah.
But I would say that Shelby, I just sent you that to post on Black Belt, that Muay Thai fighter who reduced with the ring. He went up to the ring rope and put his ring rope underneath there. Great idea, fulcrum, and then he squeezed down and it just relocated.
Yeah.
Obviously, he's a chronic dislocator. Otherwise, he would.
Right. Yeah, I've seen some guys, they put like some kind of bottle or something and just, I had one of the YouTube video. I have you did the technique. I put my arm underneath and then said, that works too.
I used to do it. I did a towel roll. And I and then I just push down on the humerus. But what I didn't like about that, it just applies so much torque to the humerus, pushing down on the elbow with that. I just felt like it was so much torque and a bit more painful. And then I started moving to this more axillary pressure I do. Yeah.
Cool.
Yeah. So for younger athletic trainers, obviously, Toki, you have a simulator, but do you have any other ways to practice relocation?
Well, I mean, so that's the thing. I mean, now they have to teach, but all those clinical professors, they graduate from OKD standards, so they don't know, they didn't learn, so they buy it and it's like, well, and then we want to teach, but we don't know how, so it's like, okay, we can do workshop. I do that, So the strange thing is, if you buy my product, they have to learn how to dislocate the joint on purpose.
Interesting.
So my elbow model. So you have to dislocate, right? And then you have to reduce. So it's like, So
show the elbow model again.
Elbow model.
Cool. So he's dislocated right now, right?
It's dislocated. Yeah. So, just sit in position, maybe, and then push and pull in.
Okay.
Yeah.
Okay. And then how do you dislocate him?
And just little turn.
Okay, you rotate him. You rotate him, dislocate.
Yeah.
Okay, cool.
Yep.
Right. Great product. Great idea. And I love it again because you're answering a question, and the question is, when are we going to have an opportunity? We watch all these videos of other people do it. We can never get our hands on anybody to do it, because even if we did, somebody would probably take over. They get scared. I do that too on my own athletic trainers who we hire. I get worried. I'm like, I got to do it. And I jump in. That's mine. Huge fault of mine. But I love the idea here. Great.
Yeah. So yeah, now I do. That's my main thing is now is a workshop. I don't sell my product anymore. Just got too busy, and there's a company took over my sales part of it. So just I can focus on workshop. So I do nothing but workshop and go places, go conference, and so.
Great idea. Cool. Great idea.
Yeah.
Yeah.
Ethan, what's the craziest dislocation that you've seen or had to deal with?
Well, we had years ago at PAMS, we had a tibiofemoral dislocation, and that's a rarity. It was a female semifinal fight in Irvine, and her tibia was completely pulled forward, and it was like tinting the skin really, really bad. Her patella was relocated, so it must have been stretching the heck out of the patellar tendon. Obviously, her cruciate ligaments are probably gone.
Yeah.
So I had her on her back, hip at 90, knee at 90, and I straddled her lower leg. I squeezed her lower and I pulled it. So I had my hands on her like hamstrings and I pulled with my body and I pushed posteriorly and it went back in. Does that make sense? Yeah. She ranged her knee. I did her just basically sagittal plane ranging. Then I just did kind of like a little meniscal ranging. And she goes, I want to go. I go, there's no way you're going to. So, but here we go. She went, she played half guard right away and she stopped right away. So I gave her the opportunity because it wasn't a concussion or neck injury, but her.
Right. Oh, shoot.
Yeah.
So that was probably the gnarliest one. The ones that look really, really bad, like patellar dislocations to the crowd, the ankle dislocation with one of our big fighters we had years ago looked really, really bad. So I think, visually some of these look really, really bad, but they're not hard to relocate or reduce,
Yeah. So legalities. I mean, I know California is a little different, so I'm sure Ethan, you have Dr. Elmo, I guess, who oversees you. But obviously for legality reasons, having a supervising physician, talk to them about it and talk about the risks. Reviewing pertinent employee related documents when you're looking to relocate, and then written standing orders, and then checking that your malpractice insurance coverage is going to, cover you in these situations.
Mm-hmm.
But any other problems that you guys see with dislocations that people should be aware of?
Scary parents.
True.
Parents are like my biggest fear, and that's why working kids events are really hard for me now. Parents they could just turn on you, and athletes can turn on you too really, really quickly. Athletes either love you or you're the villain, and parents are the same way. They either love you or now you're the villain. So I'm more scared of the parents and them wanting to be litigious than I am about anything else, I think.
Yeah. Anything from you, Toki?
I mean, like I mentioned about protect myself, protect yourself. That's the thing you can do. And even though, like I said, people can come after you. So
yeah,
I hate to say it, but
yeah, I think that's everything in athletic training, right? We're either completely loved or we don't get a lot of recognition for all the great things we do with athletes and the tenure that we do with some of these teams. But when you do one thing wrong or they think you did wrong, then it's let's blast you all over social media, let's blast you to the public, let's blast you to to the professional standards. So it's really, really hard. But I just think that athletic training should have a little bit more leeway to start some of these things that we see so much, to waste resources and call it paramedics, waste resources in the ER, for some basic medical things that we could do. I mean, it makes a lot of sense to me.
Yeah. But it's like you also say, it's a process now. All the athletic training program, they have to teach you reduction technique, and they start teaching it, and then hopefully they learn, and so when they see the first one, and then they get to do actual reduction instead of, like you say, instead of going to the emergency room and they get reduced right away, and all they have to do is next day get an X-ray, AP lateral, start doing the rehab right away, and they still 4 5 weeks out, maybe 2 weeks, you might be able to play, in the senior year. That's a great outcome to me. So hopefully get to that point.
Yeah. Yeah.
Well, and I think even just the traumatic situation, being able to quickly get them out of pain instead of, the one at JJ Con this year, she was sitting on our table for 45 minutes before the ambulance came, and she was in a lot of pain. Like
Mhm.
her partner was about to kick our asses, to be honest. Uh,
Yeah.
and then I don't know how long it took her to get to the ER and how long it took to actually get reduced. But yeah, that one was a tough one, and I think we should have probably tried again, but everybody was not giving up, but it just was so difficult, and we
Well, I
spent a
think,
lot of time on that one too.
yeah, you're talking about the girl with the hip.
Oh
Yeah.
no, the girl with the elbow that we sent.
Oh, yeah. Yeah. And I think, it's patient by patient. When you're getting so much resistance through, verbal and physical information,
Mm-hmm.
really hard. It's really, really hard. And, here we are hanging on these elbows and there's, could be screaming, either here or in the ER, or do they, because of that's so visual for everyone around us because we're not behind a tent, it's like, okay, when do I stop? And I am going to stop because you visibly and emotionally, don't want this treatment. So now you're going to wait 90 minutes or more to the ER. Yes, you will be anesthetized, but how, to what end did we apply, so much tissue tension that now you're going to have, irresolvable problems for a long time, so it's a hard go between, so I think we try multiple times and try effectively, not just, oh, I tried, like really, really try. And then, okay, then we got to let it go. That's what we go.
Yeah,
And
I
I
mean,
ate up my table that I didn't get a chance to reduce. It really hurt. Like we're pretty just about everybody. So to me, it's like, oh, come on.
Yeah.
I mean, it's football nowadays. They have a tent. Just it's everything is covered now these days to protect their. So
Yeah,
they,
you're right. Yeah,
that's the difference. Huge difference.
no, you're totally right. We haven't done that in athletic training yet, but maybe it's coming. Maybe it's coming. We do try to, like, for the suturing stuff and for other stuff, maybe if they have to degown, maybe we take them, and there's been like media tents we've used for that. But as far as
little pop-up tent, and just you got put the little cover around it, just protect the views and like something like that.
Yep.
Well, anything else on dislocations that you guys want to give your 2 cents on?
Try.
Well, and also it's like he said, it's a judgment call. People say, so you reduce everything. No, I mean, if you don't comfortable, don't do it. There's nothing wrong with that.
Mm-hmm.
And then people say, so you encourage people to reduce dislocated joint. I don't. I'm not a doctor, but I have a doctor back me up, so that's why I do it. And
Mm-hmm.
a lot of trainers, they don't do it because they don't have that connection. They don't have the support, so that's why they can't do it. They don't do it.
Yeah, lack of confidence.
So how are you gonna build that? So it takes time, and you go to the doctor's office. You have to, ask questions. You have to show what you know, what you don't know. They're trying to build a relationship. They will trust you. I mean, I don't know where you came up, and they're not gonna know you. They don't trust you. You have to build.
Mm-hmm.
So
Yeah. I always try to tell people too. I think I did an EMT certification in my very, very early years of athletic training. I found it so helpful because there's so much trauma in EMT and the rotations you do either on the rig or in the ER. I think I spent like a week in the ER. I saw so much stuff that I would never see as an athletic trainer. And then it just builds confidence because you're there and you do that, right? Athletic training, some trauma, comes, but it doesn't come sometimes as much as you see like in the ER. So I always advise people, hey, do your EMT rotation. It's a great way to evaluate too. They have a different evaluation system. I think it's really great. So I always try to advise people to do that, new and up and coming students.
Yeah. Well, that's where I always encourage athletic trainers and students to come out for our jiu-jitsu events because you get more reps in 2 days than an 8-week rotation sometimes.
Yeah.
Well, I was going to run through some facts from a study. So 2021, there was a survey of 772 athletic trainers, and 46.5% received training from their CATIE accredited school, Don't know what that training was.
Well, that was the problem though. They say you have to teach, but
Yeah.
they didn't say how. So
No
some
practical
program
portion,
they show
probably.
the YouTube video, we're done. But it was seriously. And some they purchased my model and then it's like, can we come for workshop? Yeah, I do that. But some's like, no, we showed a YouTube video. That was it.
Yeah.
So
Yeah, 64% were trained by a physician. 90% of those athletic trainers relocated with or without a physician, and 10% had not relocated a dislocation at all. So, kind of crazy. I mean, I feel like there's this perception that everybody's uncomfortable, but if 90% of athletic trainers are relocating, I think it's not as taboo as we think it is.
Yeah, maybe. And I'm teaching. Gosh, what book am I using? I won't quote the book actually, the text, but in bold letters within the shoulder chapter says, "Do not attempt to reduce injury."
Mm-hmm.
So it's still being taught, at least through textbooks. Current textbooks don't reduce.
Yeah.
But that's good info, Shelby. That's good.
Yeah.
So, what trends are you guys excited about in athletic training coming up? Toki, I'll let you go first.
Well, the medical simulation is extremely huge. I when I made this my model, I didn't know anything about it, but this called IMSH. It's huge, and more products coming up, and any field people using simulation, and I think we're gonna have more medical simulation product for athletic training, and also to me, every profession is, I don't know, evolving is the proper word or not, but now we got to teach, you got to do suture, we got to do IV, which I'm not comfortable IV, be honest with you, but you got to do more and more, and so it's going to be interesting. You might be able to, have to carry portable ultrasound machine, and we take it and send it to the doctors, reduce it. It might happen now. We have pretty much now these days. Every AT has the AED. We didn't have it. I didn't have it when I started. So,
Yeah.
Technology.
Ethan, what about you?
Yeah, I've been really high on suturing, just because within our job position, we see a lot of lacks, so I think the ability to close a wound via simple suturing is great, or stapling. We save people a lot of time, a lot of money, a lot of stress and frustration. And if we understand wound care, I think we can really advise on good advice and do the job. And if they're teaching it, then we need to start implementing it.
Right.
Yeah.
Exactly.
Yeah.
Definitely. If you guys could foresee the future, where do you see sports medicine in the next 5 to 10 years?
We're gonna see more. I mean, when I started off this profession, there was nothing. I mean, you couldn't. There's nothing. No job for Amazon. I mean, now we have or auto industry that's a safety specialist. So it's going. I mean, hopefully, maybe 10, 15 years, we might see athletic trainer up in the space. Maybe.
So you're talking as far as job careers, or you're talking
as a job, yeah. We just
yeah. I'm even asking Shelby because I feel like everything's like wearables and data collection. With an Aura ring, a Whoop strap, everything is wearables. Everything is data collection. More data. We don't know what to do with half the data, but we're collecting data. We love to collect data. So where can that data take us? What will AI be for sports medicine in the future? What does that mean for our jobs? I just think everything is tech. Everything's data. I mean, Toki, you're doing tech, right? It's low tech.
It's a low tech. Yeah, you're right.
Well,
technology,
not
low
computerized.
You're going to add to this. Soon you'll be able to have some type of wearable accelerometer on there at what joint force, at what speed, at what velocity you're actually reducing. As somebody, maybe somebody buys your product and on it. But tech is everything. So
yeah, the University of Ohio, they do that kind of research. How much force you need to do, which direction, how much extra rotation you need. So Let's see.
Yeah, it can be done with accelerometers and everything that's already in tech today. But we have a lot of tech in helmets, football helmets, because of velocity hits, high velocity hits. So that's where I see sports medicine, and with the adventation of AI, what is that going to do for us?
Right.
Yeah. Well, I'm hoping that with all this scope of practice of the relocations, the sutures, IVs, that we are going to be able to break away from physician oversight. I think we'll be almost as close as PAs. I'm not sure what's going to differentiate us other than school, but I mean, I can see us running our own clinics and having more autonomy with having private clients and being able to provide public health care. Ultimately, that's where I'm kind of seeing it with what they're incorporating.
Yeah, to add on that, I mean, really, just like PT, they have specialties, right? So they have a specialty in orthopedics or specialties and things. Athletic trainers have been trying that. They're trying it with education, but there should be a specialty in emergency medicine or a specialty in, and we are orthopedics, but they tried the orthopedics, but there should be extreme specialties based on the number of years. So if you have 8 years of experience, then you can apply for the specialty and get certified in the specialty. Then you can do these practices. Because I still think, like Toki said, 0 to 5 years, 0 to 3 years, that athletic trainer, I wouldn't, unless they're great, I'd be pretty worried.
Yeah, I won't trust them. It's like I don't trust them.
We know KD programs, right? We both work for KD programs, so how much information these kids need to retain, and to specialize in that's a whole nother level. So you can introduce and they can be a little bit familiar, but to master, the master is going to come with extreme redundancy, which, black belt sports medicine would give them. That's extreme redundancy. You will see more ACLs at a black belt sports medicine event than you will probably, like we said, in the whole, semester of football, So. Yeah.
It's there's a Saturday morning clinic in San Antonio. There's one of the sports clinic. They do Saturday morning clinic, and it's packed. To me, that's the best place to learn. And I go there since '93, and I learned so much. But I see a lot of young ones. They don't say, "Oh, we don't have time. We don't need to go." It's like, nah, that's your call. I mean, I want to improve myself, so I mean, as much as I do it, but.
Yeah.
It's hard. Everybody's got a different work ethic. Some people put 40 hours. Oh, it's too much. Some people they put 80. It's nothing. So,
right.
It's hard. But,
right.
Yeah. Well, that's where I've always wondered about redundancies on the sideline of why do we have an orthopedic doctor? Why don't we have like a neurologist or ER doctor who can help with the trauma stuff that really do need more hands? I don't know what an orthopedic sometimes is helping me with when I've already had me check it, the assistant check it, and then the orthopedic's going to check it. I don't know what more information they're going to get at that point. So I don't know.
Yeah. Plus, like first year resident come in, they check in the ACL like crazy. It's torn. Just leave him alone.
Yeah.
It's like I don't know. It's like I know. Just don't touch.
But so great about acute medical care and athletic training is we have the luxury of not having that golden period. We're able to check an ACL, PCL, torn patellar tendons right there in front of you, and then there's no guarding. You're going to actually see it. It's like being under anesthesia. You see it right away. Whereas if they wait for Monday's clinic, they're completely guarded, swollen, and
mushy. So you can't feel that. Yeah,
can't feel it. So, I think having the MD there is cool for validation. It's cool for triangulation of the information, which is good, and it's just good to we still have to look at the pecking order, and the MD is still holds the glass of wine over us, so to speak.
Definitely. So, okay. Well, I think we hit that on the head. I think we're good with dislocations. Everybody should be doing them, right?
We should. Give it a couple tries.
So, well, thank you so much. Toki, if somebody wanted to get in contact with you, how do they contact you?
Toki at mn-medical.com, my email. They can contact me for workshop requests. If they want to purchase those, so they can send me an email, but I will refer to my distributor. So
okay, perfect. Cool. And Ethan, if anybody wanted to get in contact with you, how's the best way?
You can reach me at Black Belt Sports Medicine. Sounds exactly that. One word, Black Belt Sports Medicine @gmail.com. Or you can reach my Instagram at dr.kre. That'll be Dr. Christworth. We also have a Instagram site called at Black Belt Sports Medicine as well. Instagram.
Perfect.
You do workshop for the, I guess, for the people, the staff member, right? Once a year.
We should be. That's something
Oh.
we have a list of things that we want to do, and we're 2 parts across the world here, across the country. We all have multiple jobs, and we're trying to. We have a list, but we could, if it's something that you think that you can help us with, or we can do together, it'd be great.
Yeah. You also, easiest one. If there's no hands-on, make a video out of it.
Yeah.
Well,
we're hoping to do an online course. Hopefully 2025 is the year, but we just have to figure out the filming and finalize the curriculum. So we might have to get some video of you relocating with the simulators and add that in there.
Yeah, I'm trying to have an online course also. Then people, they want to do actual hands-on. So I'm working on a workshop online course now too. So
that's cool.
Well, listeners, be on the lookout. More educational opportunities.
Yep.
So, well, thank you so much. And this is To the Bone.
Cool. Thank you.
Thank you.
Okay. Now I just have to wait for it to upload, and then we should be good.
Cool. Thanks, Shelby, for setting it up. Good. And great to meet
you.
Yeah.
Can I get the copy of this?
Yeah.
Can I put it on my YouTube channel?